Good evening, everyone, and welcome to this evening's webinar, Navigating the Storm of Substance Use in Adolescents. Before we begin, I'd just like to make an acknowledgement of country. I'd like to acknowledge the traditional owners of the lands from where each of us is joining this evening, and I wish to pay my respects to their elders past, present, and emerging. Tonight, we are joined by Dr. Catherine Klemker, Ms. Georgia Farrer, and Dr. Hester Wilson. Dr. Catherine Klemker is a final year advanced trainee in general paediatrics and adolescent and young adult medicine. Having worked in paediatrics since 2010 in the Sydney Children's Hospital Network at both Randwick and Westmead, Catherine has had much experience in both acute paediatric medicine and outpatient care. She has particular interest working with the vulnerable young people and their families, having worked in the areas of child protection and adolescent medicine. Catherine is currently appointed as the Provisional Fellow at the Adolescent Medicine Unit at the Children's Hospital Westmead, working within the Adolescent Drug and Alcohol Cicada team, and with Complex Adolescent Clinic. Catherine will be completing her paediatric training in the Shoalhaven region next year. Georgia is a clinical psychology registrar who has recently graduated from the University of Wollongong. Georgia has had a lot of experience working with children, young people, and families in a variety of settings, including acute inpatient units, private practice, and trauma clinics. Georgia is currently the clinical psychologist for the Cicada adolescent team across the Sydney Children's Hospital Network at both Westmead and Randwick campuses. She is particularly interested in working with complex trauma and family therapy. A FRACGP, Hester is also a fellow of the Chapter of Addiction Medicine. Hester is the chair of the RACGP Special Interest Group in Addiction. She works for South Eastern Sydney Local Health District Drug and Alcohol Service and in general practice in Newtown, Sydney. An experienced medical educator, Hester has written widely on general practice and substance use issues and is involved in planning and facilitating the current RACGP AOD training. Hester is currently undertaking a PhD focused on GPs and patients with chronic pain and prescription opioid use disorder. I'm going to now pass you over to Hester, who's going to take us through the learning outcomes. Thanks, Hester.
Thank you so much, Bethany, and welcome to everybody tonight. I'm pretty impressed that this late in the year we have a very large group of people that have joined us for this really important webinar. So by the end of this next hour, we hope that you'll be in a position to identify the common risk factors in adolescents that are related to substance use. Understand how to screen and assess those adolescent patients, including, if you wish, some using validated screening tools. Identifying patterns of use and the common substances that are used by adolescents. Deliver brief interventions for adolescents with substance use and their families using the principles of motivational interviewing and harm minimisation. And most importantly for us as GPs, and given we've got the specialists with us tonight, Georgia and Catherine, identifying referral pathways for patients with complex needs, including specialist and advice services.
This is a case study of John. So John's mother, Mary, attends your GP practice with regards to her son, John. John's not in attendance, but Mary would like advice as to how to manage John's current behaviour. And John is a 15-year-old boy who was born in Australia, but his parents were born in Lebanon. His parents are separated and he lives between his parents' homes. And Mary recently discovered evidence of polysubstance use in John. She thinks that he's using cannabis, alcohol, is vaping, and is also using MDMA. So from this, I just wanted to see how we all feel about this presentation. So the question is, how confident do you feel in being able to manage this presentation? Do you feel A, completely overwhelmed and wanting to run to the tea room? Are you B, quite nervous and not feeling very confident at all? C, do you have confidence that you can help? And D, you're very confident in all aspects of the case. Bring me more. Okay, well, that's pretty good. Not too many overwhelmed, and some feeling like they have a little bit of confidence. That's great. So we'll keep going with our case. So you do take additional information from Mary, who is quite distressed, and she tells you that John has been disengaged from school during lockdown, like lots of young people, and he was previously high functioning at school. He was average in his academic achievement, but quite sporty. She notices that he's been mixing with very bad friends outside of school. And she does report that he comes home every night, but sometimes comes home intoxicated, she feels. Importantly, you do ask about whether she feels safe and whether there's any violence in the home, and she reports that there isn't any violence. And she says that she wants to bring John to see you, and pretending it's for vaccination. So what do we think about that as a plan? With young people, rapport building is obviously very important, and I think we'll all agree that it's a bad idea for Mary to bring him in under false pretenses. That said, you could offer to have Mary bring him in for a health checkup, a general health checkup, and build rapport over a couple of sessions before actually addressing substance use directly, as a way to actually bring him in. If Mary did say it was for his substance use, he may not come in at all. Another thing to consider in this case is that there is a potential mismatch of cultures, with his parents being born in Lebanon and he being raised in Australia. Expectations and cultural influences are very different. And we have the recent stresses of having disengaged from school during lockdown, and really feel like we need some more information about his home environment there, about what is actually going on at home. So this brings us to the question about what John is using. It was mentioned alcohol, MDMA, cannabis, and vaping. And are these common substances in adolescence? Well, what we know is that, so there's an Australian secondary school survey that's undertaken every 2 years of over 20,000 secondary school students. And their last results available are from 2017. And what we know is that the top 3 substances used by adolescents continue to be, number 1, alcohol, tobacco, and cannabis. There are smaller percentages of adolescents who use amphetamine type substances or sedatives, but the harms associated with their use are often greater than the top 3. And just under 1 in 10, 14 to 17-year-olds have recently used an illicit drug. And that's halved since 2001. So what we can see over time is that over the past 15 years, there have been decreasing trends of adolescents drinking alcohol, but you can see that there has been little change in the patterns of adolescents binge drinking and risky drinking. Similarly, with tobacco, the number of smokers has decreased steadily over the last 15 years in both 12 to 15 and 16 to 17-year-old age group, which is very good. We have, however, seen an increase in vaping, and although the absolute numbers remain small, there are some concerning features about that trend. And also we have seen the only substance to actually have increased in the last decade or so is actually the use of inhalants amongst young people, which is also quite disturbing. So just a little bit on the stages of substance use, which is important to keep in mind when you see a young person, that the stage of adolescent development does influence the pattern of substance use. So John here fits into a middle adolescence sort of group, and in that he is using polysubstances for their effect. He probably has access to more substances than an early adolescent, and his risk-taking might be linked to his confidence. And you see in early adolescence more experimental use and using what is accessible, and that leads to the higher level of inhalant use amongst early adolescents because they have that access. And so if you do have an established pattern of substance use in an 11-year-old, that really does not fit with the developmental stage of that young person. And so that would be a red flag to warrant referral to specialist services. And in late adolescence, the pattern of substance use is more settled. Keeping in mind that the actual numbers of young people using are small, but are significant, and they may well present to you. Georgia, can you tell us a little bit more about comorbid conditions in mental health and substance use?
Yeah, absolutely. And so I think it's important to kind of identify the overlap that we see with a lot of mental health disorders, neurodevelopmental disorders in childhood, and they're linked to substance use. And so we know there's an increased risk of substance use disorders when there's a childhood diagnosis of ADHD, so attention deficit hyperactivity disorder, oppositional defiance disorder, conduct disorder, or depression. And we also know that adolescents who engage in self-harm have an increased risk of a substance use disorder, weekly cannabis use, and social disadvantage. We also can see a link between symptoms of post-traumatic stress disorder, complex trauma or developmental disorder, and they're common in adolescents who present with problems related to substance use. And sometimes these diagnoses can be a red flag or kind of just an indicator that you might be needing to ask about other comorbidities, including substance use for a young person. In particular, ADHD and substance use have a significant overlap. And this is for ADHD that is both diagnosed and undiagnosed. So ADHD is the most common neurodevelopmental disorder for children and adolescents. And kids with ADHD are 2.5 times more likely to have a substance use disorder in adulthood, which could be due to a range of kind of factors. And treatment for ADHD is usually with stimulant medication, which reduces the symptoms and also reduces the risks of substance use disorders. But stimulant medication can have a really high abuse potential. And so what we see is there's this two-sided kind of debate about prescribing stimulants to young people who have a substance use disorder, because they can be traded on the streets and things like that. And it's important to kind of monitor their adherence, side effects and interactions, but also closely control prescriptions and prescribing for stimulants, and making sure that there's safety measures in place for parents to provide the young person with the medication, and making sure it's monitored just to kind of reduce that risk that it could be used illicitly. I think going back to our case study, Catherine might be able to take us through a little bit more and kind of unpacking what's going on for John.
Thanks, Georgia. So if we think about our case study and what we actually need to do, so when John comes face to face, what you want to be doing is thinking about what you need to actually get from this young person. But there's a question for everyone as well, and how do you balance getting the information that you need with building rapport with this young person, someone that you're going to have an ongoing relationship with and presumably want to deliver some interventions for, and which requires a lot of rapport with that young person. So I think in that case, when you plan to see the young person in the clinic, there would be some information that you can get from mum that you don't need to necessarily get from John himself. And, particularly around background history. and around past medical history and developmental history. It's really important to set aside time to see John if he's coming face to face. And I know that in the pandemic, we've been doing a lot of telehealth, telephone or video, and there, in this sort of situation, there is a limit to the rapport that you can build over the phone. And really, it's very difficult to be able to assess the risk of that young person from a mental health point of view, do any sort of mental state exam, even, see what his engagement is. So we wouldn't recommend doing this sort of thing over the phone. If needed, I would suggest maybe doing an introduction over the phone and as a way to introduce yourself and then bring him in to see him face to face. It's very important, as I'm sure everybody knows, to see that young person on their own. And often, that might involve seeing Mary and John together initially, or maybe for the initial appointment, but making sure that there is time to see the young person on their own. We always would recommend a discussion about confidentiality, and it's really compulsory. So we always say that there are limits to confidentiality. So I might say something about like that I wanted to have a chat with him, and that what we say in this room is confidential between us, and I don't need to tell anybody else about it. However, if I'm really worried that there's a risk to yourself or a risk to other people from something that you've told me, I do need to tell other people about it for your own safety and well-being. And I always say that if that does come up, I will tell you about it and we can work out how to do it together. But that's really important, that those limits are made explicit to the young person. Otherwise, they will be completely betrayed when you do have to make a report to child protection or tell parents about something that's particularly risky. In terms of legality of treating a young person and confidentiality, over between 14 and 16 years of age, you can assess the young person as a legally mature minor, and that's backed by Australian common law, but not in legislation itself, and is known as Gillick competence. And what that essentially means is that, and it was established by a UK legal case around treatment with contraception on a 15-year-old or 16-year-old girl in the UK. And so that means that that young person can give consent to being examined, to having simple treatments, if you feel that they have the intellect and the understanding to engage in that. And that's really a clinical decision for you. Just another hint, if you are talking on the phone, just remember that to ensure that the young person is in a private space. And if you have any doubts about it, I would suggest just curtailing the interview. The other important thing is to have contact details for the young person, not just for the parent or caregiver themselves.
Catherine, I'll just interrupt there. So Penelope has made a comment and asked a question. So she finds as a GP that having that telephone conversation or telehealth conversation is quite useful as a first kind of point of call, because the young person gets to meet her and it's a little bit more comfortable before she then moves on to the face-to-face consultation, and is saying, so maybe this is actually a silver lining of the pandemic.
Maybe, and there's more than one way to do things, absolutely. So I think that it sounds as though if you're trying to build rapport before you're threatened being a bit more direct or possibly confrontational with the young person, or they might perceive that as confrontational, then that's always a good thing. Now, in terms of assessing him when he comes, we like to start with a history, and I would make sure that the medical history is complete. And that doesn't all have to be done on the one day, but medical history and past surgeries and medical illnesses all do have an impact on the young person and where they are. You know, there may have been traumatic incidents associated with being in hospital. It's really important to have all that history. And, you know, you may already have a lot of it if you know the family well. Developmental history is important to think about as well. Cognitive impairment, ASD, ADHD will all impact on substance use. And, you know, without having to do a full developmental assessment, which is impossible in a short space of time, but knowing something about the developmental history and considering it is important. Mental health history is very important, as well, as Georgia told us how mental health and substance use really do go hand in hand. As we should with all young people, no matter what they're presenting with, a HEADS assessment is really important. And as always, we try and start with the benign in the HEADS assessment and introduce the sensitive. Another thing to consider is the family history, including substance use. Is there alcohol used in the house? Are there other substances used in the house? Has there been exposure to substances in utero? Who, you know, the family can be even supplying the substances, and so making that clear will determine what sort of message you have to give family as well. And of course, we want to know a substance use history with our young person. So this is just a reminder about HEADS and all the things to ask about, which I'm sure that everybody knows about, and just some ideas about how to approach questions. And sometimes, in general, keeping a very curious and open mind is a good way to go. And, you know, using a third person approach, like some other young people I talk to say this. Many young people your age experiment with substances. Do you know anyone who does? And really introducing that you're going to ask personal questions. So asking, if it's okay with you, I'm going to ask some more personal questions once you've dealt with the benign. And asking them what they really feel about something in an open-ended manner is helpful too. So what do you like about, whether it be school or whether it be MDMA, or what don't you like about it? So physical examination, which we all like to do as doctors as well, is, I can't understate the importance of either. And that's why really face-to-face exam is important. Doing a mental state exam when the young person is in the room, just observing them is really important. And then doing a physical exam with their consent is important. Patterns of substance use may be associated with disordered eating and weight loss, or weight gain, usually weight loss. And it's important to document that and see where they're at. Heart rate and blood pressure are very important as a baseline, and also in terms of whether the substances they're using are affecting the cardiovascular system. A general examination, and then a directed examination based on your findings. And I would just pay particular attention to look for signs of intoxication in terms of their behaviour, but also in terms of any injected conjunctiva, any tremors, any unusual behaviours. And looking for signs of self-harm is important too, thinking about those comorbid mental health conditions. So when we actually get to taking a substance use history, Georgia, can you tell us about what we need to ask?
Of course. Sometimes it can be really scary asking about substances, especially if you don't have a lot of exposure to them or don't know what they're sort of adolescents are using at the moment. So these are just some of the prompts that we go through to find out what young people are using. And we often like to do this rather than just taking, say if they say they're using cannabis once a week, it's finding out a little bit more about it. What's the pattern? And that will help us kind of identify where in that substance use stage that they are, and kind of where or how severe their presentation is and where we need to refer to. So sometimes, even in our drug and alcohol service, they know they're coming from drug and alcohol, but we like to say, lots of young people try drugs and alcohol. Do you know anyone at school has tried them? Has your friends? Have you? And sometimes that just opens up the question about what their friends are using. And you can kind of go, have you ever tried that? Have you ever wanted to try that? And things like that. So first off, it's kind of finding out what they've tried and getting a really detailed history. And sometimes even I find it helpful to have a list of substances in front of me that I need to ask about. And there's some really great substance use kind of history templates that you can use and jot down. And it's about how much have you used, how often, and the pattern of use and things like that. But you want to get an understanding of how many times have they used. Is it kind of a one-off experimentation that they've kind of tried and put to bed? Is it something that they're doing regularly, or kind of just when they're out in a certain group of friends? Is it a daily thing? Kind of finding out how many times and for how long. How often they use is kind of the same thing. Finding out sort of, is it a daily, is it a dependence kind of thing that we're looking at? It's a daily thing that they're using to cope with something. How much do they use? And finding out whether that's increased or decreased from when they've started. And we often find that with cannabis is that how much are you using now? Because often young people become tolerant to it and they need more and more to kind of get the same high that they're looking for. So asking how much they use, and sometimes it's hard to know what it comes in. So it's asking for cannabis, how many cones have you used? Do you use joints? How many grams? How much are you buying in one go, and how long is that lasting? And that gives us a bit of an idea of the amount that young people are using. But it also can be conversations around, can be for alcohol, how many standard drinks, and a little bit of education around that. And it can be also in terms of, say, if they're using benzodiazepines or other things, finding out the milligrams of the tablets they're taking. And some young people don't actually know. They kind of estimate or guess what they've taken, but it's getting them to be a little bit more aware of it and what the effect then could be. Finding out when the first kind of time they tried any sort of substances is really important in terms of their development and kind of their exposure. We have a lot of young people that we see with more severe substance use disorders start really, really early on. And that's often when they're exposed to substances at home or kind of in their friends group at an early age. And so finding out when they have started is really key as well. When the last time they tried a substance is, and that might be that it was one-off or it's a current thing. How do they take it? And there is a bunch of different ways to take different substances. So asking them, and sometimes it's around clarifying, did you sort of snort that kind of powder, or did you take it as a tablet? How did they take it? Was it a cone or was it a joint for cannabis? Who do you use with? That'll give you a bit of an idea about who their friend circle is, whether they're using it by themselves, because that's another kind of red flag if they're starting to use a lot of substances by themselves. And what about, have they ever tried to stop? Have they ever tried to quit, and what's got in the way? And asking about if they're interested in stopping, like, is this starting to get in the way of what they want to be doing? Is it starting to get in the way of friends and family or school? And asking those questions can really help us kind of lead into some of the brief interventions that we'll talk a little bit about later. But I think what we'll do next is, if we go to the next, it's getting there. So we might have a little bit of a think about kind of the spectrum of substance use disorders. And this is kind of what we were talking about, and it helps piece together with all this information. Is it kind of casual experimental use that's not really problematic? A young person tried a drink of alcohol once, hated the taste and never want to try it again. Is it something that they do really with no kind of effect? They had a puff of a cigarette or had tried one of their friends' vapes. We're thinking that they're probably not the problematic substance users that we need to be kind of thinking about. Sometimes there's beneficial use. So sometimes they're using it like other substances, and we're thinking like coffee and tea that we all drink to stay like kind of awake and alive. They have a beneficial use. They kind of give us this kind of up and kind of some energy for the day. Maybe it's a bit of red wine, which is alcohol. It has a beneficial use. It's allowing us to socialize. It improves our kind of gives us a nice feeling and things like that. At the other end of the spectrum, we're starting to get into more problematic and chronic use or chronic dependence. So problematic use is when we start to see that it's having an effect on a young person or a person, on their individual, their friends, their schooling, the society. They're starting to get in trouble with police. They're starting to miss days of school. When we're starting to see it have an impact, we need to think about what we can do. And right at the other end is the chronic dependence. And so sometimes we see young people, particularly with cannabis or maybe benzos, that they have this dependence on the substance and they're no longer getting the kind of high that they're looking for. They're kind of taking the substance just to kind of remain at baseline. And that's when we're thinking about how do we manage dependence and withdrawals if we ask the young person to cut down.
Georgia, just got a question from Anusha. Is there a certain amount of cannabis use, for example, number of joints a day or grams per day, that is more concerning?
I think with any substance, the more they're using, the more concerning it is. It depends really on the young person. So joints have more cannabis per like grams in them than cones, and cones are used in bongs. And so finding out how much a young person's taking and whether that's changed over time. So often they'll start small and then increase, but it also is helpful to find out how many times during the day they're smoking. So sometimes young people will use a fair few cones, like 5 to 10 cones at night, and that's enough for them if they've been using for a while. But sometimes they're kind of remaining high throughout the day. So they're taking 2 cones out of every hour. And we know that those types of changes, or kind of whether there's, and some young people will only smoke at night, and we know that their cannabis use is maybe getting worse when we see them starting to smoke at lunchtime or in the morning, or waking up and needing a cone. So I don't think there's a specific amount more is worse, but I think it's individual, and if that's increasing over time, or they're more and more smoking more and more throughout the day, that's when we need to kind of be thinking that that's getting into the problematic use.
Absolutely. I'd agree with that, Georgia. And at that point, you'd be thinking that this young person needs referral on to a specialist service. In terms of cannabis, though, we see young people who smoke 3 grams a day, which we would say is a lot for a young person to be smoking. Just to give you an idea of what young people are smoking, and they would be at the severe end of people we see.
But yeah, and we also have young people that only smoke 1 gram a day, but are dependent on it. And so it kind of just depends what else they're using and kind of when they're using it. So I think there's a spectrum, particularly with dependence. But using screening tools is a really helpful way of kind of quantifying what a young person is using and kind of using that to measure over time. So there's a whole bunch of different kind of screening tools. And the first one that we kind of use to kind of, it's a way of identifying sort of red flags or risk of harm. And I would be doing this kind of with a lot of different young people, not even if they've kind of reported substance use. I'd be doing this across the board. But the CRAFT screening tool is a fantastic way of kind of identifying whether the adolescent is putting themselves at any kind of risk. And so the CRAFT stands for car, relax, alone, forgotten, friends and family, and trouble. And so it's asking about, have they ever ridden in a car with someone who's under the influence of drugs and alcohol? Have they ever felt like they needed drugs or alcohol to relax or to fit in? What about, have they ever used it alone, which is another risk factor if it's not just socially? Have they ever forgotten anything whilst using drugs and alcohol? Particularly with benzos, lots of young people report forgetting what they've done, but it might be that their memory is getting worse with their cannabis use and things like that. Has anybody ever told them that they need to cut down? Has their parents kind of encouraged them to cut down? Are their friends telling them that they're using too much? And have you ever gotten into trouble while using drugs and alcohol is another big one. A lot of young people come in contact with law enforcement when they're under the substance uses or come into the hospital and things like that. So these are kind of a great way of just sort of having some red flags about what you might need to be asking about. There's some more specific drug and alcohol questionnaires that you can ask around specific substances. So we've got the audit and the QDIT on the screen at the moment. And so the audit is around alcohol and the QDIT's around cannabis. And there's actually a variety of different kind of screeners based on those two measures for other substances as well. But then we've got the HONC, which is the Hooked on Nicotine Checklist. And this has also been updated to include vaping as well. And so I know on the screen it says smoking and tobacco, but there is a version that says vaping as well, because we're finding a lot of our young people are using vapes instead of smoking cigarettes. And the severity of dependence scale is another really nice measure to kind of get an objective idea about where their dependence is at. And so it's thinking about their most concerned substance and how much they're thinking that their use is out of control, not being able to use it, what happens when they can't. And that kind of a score greater than 3, which is not hard to get on this scale, indicates likely dependence. And we need to be thinking down the track. And if they are dependent, where we need to refer them and how we can manage help withdrawals. And so, Catherine, I think we might kind of keep going and sort of work out, now that we've kind of done an assessment, how we kind of might move into the next phase.
Absolutely. So if we return to John, and when we do get some substance use history from him, we find out that he used MDMA once only at a party with his friends 2 months ago. And he didn't really like it and doesn't really plan to use it again. He uses alcohol at parties with his friends, parties, probably friends in the park. And 2 or 3 of his friends share 1 bottle of spirits about every 3 to 4 weeks. He gets drunk, but he is, plans to continue doing that. He is vaping daily, and he uses disposable vapes, which he obtains from his local convenience store. And they're labelled as 5% nicotine, and he uses 600 puffs every 2 days. And he vapes first thing in the morning and all the way through the day to bedtime. The longest abstinence period he's had is just 24 hours. And after that, he just can't handle it anymore. He started about a year ago. He's increased the amount that he's smoked over the last year, and he has cravings when he doesn't have it. So he's showing signs of dependence on nicotine, and his alcohol use, I'm sure you would agree, is quite risky. He first tried cannabis last year, and he regularly started smoking 4 months ago, and in the last month has been smoking every 3 days, which helps to calm his mood. And I guess, given that I'm a bit concerned about with dependence on nicotine, but also he smokes cannabis every 3 days and it helps him calm his mood, I'm a bit worried that he's developing dependence on cannabis as well. So I just wanted to show you this graph about cannabis withdrawal, and it's important to check for withdrawal symptoms if you're seeing a young person like this. And cannabis withdrawal symptoms are usually worse day 2, day 3 to day 4, and they can often present with decreased appetite, insomnia. They can be really irritable, maybe verbally or physically aggressive. And that might be the way that they present. And if you're seeing that sort of pattern whenever they stop, then thinking about dependence and actually having withdrawal symptoms is important. And if you are thinking that there might be withdrawal symptoms, that definitely warrants a referral to a specific service. The other thing that you can do when you see is to consider and manage comorbidities, which is really important. So number one, I would say, being mental health. Does this young person have a primary mental health disorder? Are they having mental health effects of their substance use? Are they using their substances to self-medicate their mental health symptoms? Anxiety and depression are probably most common. And of course, fluoxetine would be the first line of medication use, along with psychology for that, and a referral to mental health, which we know now more than ever is more difficult for families. Also thinking about psychosis and asking about any particular symptoms of psychosis, because they are associated with substance use, particularly in this case cannabis in John, but may also be underlying. Thinking about sleep and eating is really important. Sleep hygiene and nutrition in all young people is an area of that needs attention, and considering melatonin might be something for them if they're having particular trouble with their sleep. Considering whether ADHD is part of the picture, and as always, we have opportunities to screen for other associated health problems, particularly in young people, sexual health. And despite lots of education, young people can be quite oblivious to sexual health needs, and it's not on their priorities. So STI screening, whether that be simple urine testings for chlamydia and gonorrhea, which chlamydia is very common, as you know, and a discussion about contraception is really important. It can also be a mode for catching vaccinations. If there's school refusal, which can be the case with young people using substances, that may lead to missing their school-aged their high school vaccinations. So that's important, and diet and nutrition. So just a little bit more on sexual health. Risky sexual behaviours are common in adolescents, in particular those who are using drugs and alcohol, not surprisingly. Also, young people who use drugs and alcohol are particularly vulnerable to sexual exploitation and abuse, and that's really important to remember. It can be an opportunistic screen for STIs and education about safer sex that you can provide to those young people. So we come to another point in our presentation when we want to ask your opinions about something. So I just wanted to ask, how comfortable do you all feel about adopting a harm minimization approach rather than abstinence from substance use with young people? And if you can answer, that would be great. Very comfortable, that's what you do. You're somewhat comfortable with harm minimization aims. You may have some reservations about promoting harm minimization, or you may only be comfortable with promoting abstinence. I just wanted to address a question while we're doing the poll, I guess, about vaping. So I was just with 600 puffs a day. I put that in because we understand that 600 puffs of 5% nicotine is about equivalent to a regular pack of cigarettes. So I think John was using that every couple of days. So that would be half a pack a day of a cigarette equivalent in terms of nicotine. That said, we know that the labeling on vapes, which are, as you know, very unregulated, that the young people are getting, those disposable ones, can be very variable. And studies that have actually analysed the amount of nicotine have ranged from very low percentages to really extremely high percentages. So there's a lot of unknowns with that, with vaping. And the reasons a lot of young people say they vape a lot from the morning to the night is because it's so easy to do. We have young people sometimes vaping in sessions without us even noticing much, because it's just so easy to do. They vape in class, between classes, unfortunately.
All right, so I'm just about to share those results with you, Catherine.
Thanks,
so
Bethany.
just up on your screen.
So I think we've got a good spread of answers, and understandably, I think we all have different views on substances and substance use based on our history and our experiences and our underlying core beliefs. And I think that's important to note. And I think it's also important to reflect as doctors and other professionals about how our own views affect the way that we interact with young people. So we do, I'm going to throw to Georgia to talk more about our approach and harm reduction.
Thanks, Catherine. I think we saw from that kind of poll is that there's some people that are kind of confident with harm reduction or harm minimization, but it's actually it feels quite a scary thing to do because it almost feels like you're promoting drug use. But what we know is that telling young people not to do something doesn't work. And so it's about how can we make what they're doing safe, and how can we provide them with the knowledge and kind of education to make safe decisions and informed decisions. And so a big part of what you can do with young people, like say John came in and he told you about this, sometimes it's helpful to kind of do some safety planning or provide him with some education about what he's using. So it's about providing drug and alcohol education. So what information you can give him is about the harms, what kind of side effects there are, what kind of withdrawal symptoms he might be experiencing when he doesn't. And that might be in particular related to like cannabis or others, but why he might be feeling agitated, kind of helping him understand those kinds of interactions. But also, if a young person's on other medications, explaining the interactions between those, but also the interactions between different substances they're using themselves. And so using substances such as MDMA, and if a young person's on an antidepressant, being really aware of serotonin syndrome and kind of advising them of kind of interaction between those two. But if young people are using benzodiazepines as well as alcohol, explaining the effect that alcohol can increase the effect of benzodiazepines as well, and sort of helping them to understand what the risks are if using multiple or polysubstance use and how it can interact with things that they're already on. The other thing you can do is provide information around psychoeducation and how that impacts their mental health. So if there are difficulties with mood or anxiety or things like that, understanding how substances have an interplay with those and how they either can impact them or how they actually might be a coping mechanism for some of their mental health difficulties. The other side of harm minimization is safety planning. So how can a young person use substances safely in a safe environment, and what to do if there's a problem? And so sometimes young people are really hesitant about calling emergency services. So sometimes it's going over what they need to be looking out for. Maybe it's in their friends. Maybe they have a really risky user as a friend, and what to look out for them, and to be knowing when to sort of get adults involved. Finding out who they use with, where they use, how can we make it a safe environment? Can you be in a house? Can we make sure that you have contact with someone, you're not using alone? But also it can be talking about limits. How many standard drinks can you have before we know things get out of control? How much cannabis or MDMA have you used in the past? What are our limits? How much can we agree on buying on to set some of those boundaries and kind of monitor your use?
And Georgia, I might just add, just on the subject of harm minimization, while we do that, we do, and it's important to let the young person know that there is no safe level of use. Yeah. And we make that very clear to the young person, and in no way condoning substance use in young people at all.
No. But we find that we absolutely give that message and give it regularly. But we just find that if we say don't use it, just closes the conversation off from having kind of those open discussions about what they're doing. And we want them to be sharing it with us rather than hiding it from us. So there's other aspects kind of like harm reduction and stages of change that you can think about, and identifying where a young person is in their stage of change or how likely they are or wanting to kind of change their substance use will really help kind of direct what kind of intervention that you need. So sometimes it's asking questions like, what do you like about drinking or using cannabis? What are you worried about with your substance use? What makes you think you have a problem? And so finding out if they have kind of, and maybe they just love using it and have no plans to stop it at all. If that's the kind of space that they're in, maybe it's just about providing kind of psychoeducation and education around drugs. And maybe it's providing with them some resources and doing some safety planning. But if they go, actually, yeah, I think it's starting to really impact my friendships, my family, schooling, it's like, well, what makes you think it's a problem? Or, well, I can't kind of wake up without having kind of a cone. Then it's going, okay, where do you think we can go from next? Do we need to refer you? Are you willing to talk to someone about how you can reduce your substances? It's finding out, is it getting in the way of anything? Is it kind of impacting your relationships? How does it compare to your friends that you're hanging around with? Are you using more or having more kind of incidents than your friends are? Are you kind of starting to lose friends because of your substance use, or you're always using substances together? What do you think would be different if you weren't using? Which is a really interesting way of kind of asking what's going on. What would be different? What would change? And maybe it's that they could go to school, or they weren't irritable all the time, but sometimes there's things that they kind of are missing out on because of their substance use, and whether they've ever thought to kind of cut down and how it went. How can we, and if they have tried, what can we do next time to support you with that approach? Motivational interviewing is a really kind of key kind of intervention strategy that you can use with young people in kind of a really impromptu way. It's listening and hearing what they're saying, why they're using what they're using, and kind of taking that curious, non-judgmental stance that you're willing to hear what happens and help them. Asking about what it's getting in the way of. What do they like that they can't do now because they're using? Maybe it's that they loved playing footy and now that they can't run 100 meters because they're so puffed out. How is it getting in the way of them wanting to do things? Often they won't want to do anything. They'll kind of say, nah, I'm happy with how it's going. Leave me alone. It's going, okay, how can we support you in this stage? And what happens if you want to kind of start in change in the future? And in those stages, it's not about kind of lecturing or forcing them or debating whether it's a good thing or not, because often they're not in a place where they can do that. So it's about, how do I give you some education so you can make an informed decision? And sometimes that's enough. Sometimes that's enough for them to make a decision about changing how much they use, where they use, or who they use with. And really kind of pumping them up that they can do this themselves. So young people have so much resilience and so much self-efficacy that they need to kind of have that someone instill their confidence that they can do it. This withdrawing from a substance or kind of cutting down is a really difficult thing to do. So kind of just sort of drawing on their strengths and what they've done in the past and how they can kind of do that in the future. If we keep going, it's also kind of important, we flagged this before in terms of discussions around confidentiality, having in the back of your mind when you need to kind of report to child protection. And this is always a little bit tricky, and the MRG on child stories, so the mandatory reporter guide, is always there to kind of help and guide you. And I think there's child wellbeing units and sort of information that can be out there as well. But when there's significant harms associated to a young person and their substances, we need to be thinking about their safety. If they're not engaged in treatment or unwilling to, or their parents are unwilling to engage, help them engage in treatment, that's a kind of a risk factor that we think needs to be kind of flagged. If they're reporting any kind of sexual assault, it needs to be reported, including historical, and not always taking for granted for what they're saying is that never just taking that it's been reported as face value, making sure that if you're hearing these disclosures, you're reporting them yourself, making sure that if the parents are not engaging in protective behaviours or safety behaviours, if there's parental mental health or substance use that is impacting the young person, if there's prolonged school disengagement, it's also another risk factor that you need to be thinking about. And if there's a request for a assistance. So sometimes people are reaching out, and often GPs are their first kind of front line of who they go to if there's a really good relationship. If they're reaching out and there's a whole bunch of harms associated, we need to be reporting it or getting it on the radar of someone to kind of assist the family. If we keep, I'm just mindful of the time. If we move to the next slide, we can have a think a little bit about resources. So we're coming to the end, and sometimes having these resources in your back pocket is a really helpful way for young people. And it might be that you pull it up on your computer while they're there with you and you go through the list together. Your Room is a brilliant website to have in your back pocket. It's interactive, it's easy, it's so youth friendly. It talks about the different types of drugs, their effects, the interactions, drugs you've never heard of. And it's kind of all there with the slang that kids use. It's a great way. Have it on your desktop. Headspace also has some brilliant resources, lovely and colourful, that you can print out, give to young people on the different substances, their interactions, where they can get help and what they want to do. The Australian Drug Foundation is another fantastic way of accessing information. They have a brilliant drug wheel where you can click on the different kind of groups of substances, what they do and all of that. It's all interactive.
They're printable and easy to hand out too.
Absolutely. And all of these slides that will be available to you are hyperlinked as well to the websites. And Kids Quit is another fantastic resources, which does a free online course for clinicians about helping young people reduce their nicotine or tobacco use. And they have quit plans and other resources online for you to kind of use.
That's provided by Sydney Children's Hospital Network. And if you follow these, all these are hyperlinked.
Yeah. Family specific support. So we know that drug use doesn't only kind of keep to an individual, but is around the family as well. Family Drug Support is a brilliant organisation where there's a 24-hour hotline where there's individuals who have experience with substance use in their family themselves man the phones, and there's a whole bunch of other resources and referral pathways that we've included. Relationships Australia, there's parenting courses and groups such as Tuning Into Teens. In terms of referring, that Australian Drug Information Service is a fantastic starting point. So they have a hotline number and will then direct you to the state-based services that are there for yourselves. Going to, if there's a more severe use with complexity, going to tertiary hospitals. So where the Cicada Drug and Alcohol Service with the Sydney Children's Hospital Network, WIDAS is with the Nepean Hospital. You've got CAMS or KINS, which have drug and alcohol workers, which are an LHD. And you can always refer through your PHN. I've also got kind of on the next slide a whole list of New South Wales and ACT-based services. And these are easily, you can just Google these or this kind of table, and there's a whole bunch of places in your local area. If you just type in drug and alcohol services youth, there's a whole bunch of things that you can look up in your area. But I think that we've got some other resources on the slides that will be sent out to you. And DARK and Assist Y is another questionnaire that you can use, and we kind of just include a vaping cessation flowchart as well. I'm just mindful that we've hit 8:30, and I wanted to kind of.
Thanks, Georgia. We got there.
You certainly did, guys. That was perfect timing. Look, as we finish up, Catherine and Georgia, any last kind of, takeaways that you'd like our GPs and attendees to take with them tonight?
I think don't be afraid to ask. We need to pick these young people up at the start of their use. So do not be afraid to ask the really hard questions, and they're often probably more willing to tell you things than you want them to be. So ask, and just find the right path for them.
So just ask.
And I would say that there are things that you can do, and not all young people are at the severe end, and brief interventions for sort of lower level substance use can be really useful, especially in those that you've got a relationship with. So there are lots of things that you can do, which I hope we've given you ideas about today. And then those who you are worried about and something doesn't seem right and is beyond what you can do, we are always here, and there are lots of referral pathways.
Great. Look, thank you so much, Catherine. The Shoalhaven is very lucky to have you next year. And Georgia, congratulations as well. Wonderful that you're continuing to work with Cicada, and that is an option that if we need it, we might be able to refer directly to you or to your service. So thank you to the 113 people who attended. I'm super impressed at this late in the year that you guys have come along, but it was really well worth our great information from Catherine and Georgia. Thank you so much.
Thank you very much, Hester, and everybody for joining.
Perfect. Thank you. And I just also want to say a big thank you to Catherine and Georgia, and a big thank you to our facilitator, Dr. Hester Wilson, as well. And a big thanks to everybody online. I have sent that email in the chat box. So if there is anything we haven't been able to answer, please do feel free to get in touch with me tomorrow, and I can pass that along to our presenters.